Um, if y'all were like me, the diuretics kind of made sense. So we'll go through those quickly. I think what I had the most trouble with was their antiarrhythmics. Now, in term 5, we actually went through all of the arrhythmias and looked at them with EKGs. So why they teach you the antiarrhythmic drugs in term 4 and you actually learn the arrhythmias in term 5, I don't know. But when we get to the antiarrhythmics, I will tell you what you need to know for the questions that they're going to ask. Because I went into the exam being like, if they tell me it's like atrial fibrillation, I don't know what drug to give. But that's not how they tested. They tested on saying like, which one prolongs QT, and like you want to give one that is good for extending QRS. So that's what we'll look at there. But quickly we could run through the diuretics. So remember, diuretics, good for the heart, good for your vessels. You got to get the fluid off. Good for the renal system as well. So that's why cardio and renal are together, because they kind of work in conjunction with the whole volume regulation. Okay, so typically when we talk about either heart failure or renal problems or hypertension, the first line drug you want to give is a diuretic. All right, so let's get to the actual drugs. Now, loop diuretics are super strong. Okay, so they're not first line, but if a patient comes in a congestive heart failure, like full blown, like left heart failure, has dyspnea because there's fluid in the lungs, has right heart failure because of that, and now has peripheral edema, you just give them a loop diuretic. You give them furosemide, that's Lasix. You give it to them right away because you need to get all the fluid off. But when you're talking about just regulating high blood pressure, you don't give a loop diuretic first. They'll bottom out, right? They'll get orthostatic hypotension. It's not a first line for that. But when you think about heart failure and all of the peripheral edema, you definitely want to give it. So when you think of loop diuretics, think of it being really strong, okay? So management for edema. Just a good thing to know, they are used on these channels here, the sodium chloride potassium channel, this co-transporter, okay? And they obviously work in the loop of Henle. Super important to know these, my highlighting by now probably, red is super important, green's, a little less important, and yellow's a little less. So some of these are going to be more important than others. And a good thing that they actually increase renal blood flow down the line. You learn about that in term 5. So let's see. Obviously, these adverse effects are going to be super important too. Ototoxicity, okay, it changes the fluid balance in the ear canal. So ototoxicity is a big one. And then some of these other ones, you definitely want to remember these. Hypokalemia versus some of the diuretics that work downstream are going to be potassium sparing, okay? And watch out for the allergic reactions with sulfa drugs. Okay, so good little explanation here. All right, so thiazides, they're great first line drugs. HCTZ is typically the one they use, hydrochlorothiazide, works down in the distal tubule. The big question they always ask, it probably should be in red here. It causes hypercalcemia, all right? So if you take a thiazide and then you check your blood, you'll have elevated calcium in your blood. It causes hypercalcemia, which is why it's good for treatment of hypercalciuria. If you have a lot of calcium in your urine and you want to pull it out of your urine and get it out of there, you can give a thiazide. So people that have chronic kidney stones, calcium kidney stones, you can give them a thiazide and it'll get all that calcium off out of their urine back into the blood. But thiazides are very classic, prototypical for something that causes hypercalcemia, okay? So make sure you know that. And just so you know, they work on these sodium chloride co-transporters down in the distal tubule. And I remember that they deal with calcium causing hypercalcemia, because remember PTH works down in the distal tubule too. So that kind of all puts it together for me. All right, so you can see the hypercalcemia. That's pretty much the big one you need to know there. Again, can cause hypokalemia, just like loops, right? Increase potassium excretion. All right, and that'll be different from the potassium sparing ones. Now, stuff like this, like I did highlight it, but honestly, like if you asked me in the exam if I knew that, I did not. Like, it's one of those things. I don't go back after the test and change my highlighting, but things like that in numbers and stuff sometimes, it's not terribly important. All right. So again, hypercalcemia, if it's not written on your slide, that would be the big one to know. And then, oh, the mnemonic for this is glukes. Let me just put it here for you guys. GLUC, gluc. So it causes hyperglycemia, lipidemia, uricemia, hypercalcemia, and hypersensitivity. Okay, so what's important here? Watch this for diabetic patients. Okay, it's a good question to ask. Probably don't want to use it, right? Use something else. ACE inhibitors are good, right? They're renoprotective for those diabetic patients. Okay, so glukes is the way to remember that one. All right. Now, potassium sparing. The way to remember these is it's SEAL. S-E-A-L, I believe. Yeah, so these first two are aldosterone receptor antagonists. What's very specific about these, they cause anti-androgenic effects. So they can cause like gynecomastia and stuff. Okay, but they're also potassium sparing. If you're not using aldosterone, that sodium potassium exchanger isn't going to work. So you're going to pee out a lot of sodium and you're going to hold on to that potassium. Okay, and then the other one, amiloride, what's the L for? Amiloride, hold on. I'm sorry, it's SEAT, not SEAL, it's SEAT, S-E-A-T, and triamterene is the other one. Okay, hold on, let me go back. All right, so just remember potassium sparing, the ones that work on aldosterone, they have anti-androgenic effects, okay? It's like gynecomastia. And then anytime you're messing with holding on to too much sodium, or too much potassium, you're at risk for arrhythmias. Remember, that's a big problem, either hyper or hypokalemia. You have to watch out for arrhythmias. Very important, we'll get to in a little bit. It may not be intuitive, it's not to me, but spironolactone is one of those drugs that is, it helps to prevent cardiac remodeling. Okay, so there are a couple of drugs, somebody could throw it in the chat if they want, but I think we're gonna come up to it. A couple of drug classes are prevent cardiac remodeling, which is very important because cardiac remodeling causes systolic and diastolic dysfunction, right? So by definition, these drugs such as ACE inhibitors, beta blockers, spironolactone, I believe maybe calcium channel blockers is the other one, they all prevent cardiac remodeling. So they all technically help with longer lifespan, right? Cardiac remodeling is the definition of heart failure, okay? So these drugs are very important, but it may not be intuitive that spironolactone is one of those, but it is. Okay, so things like digoxin is not, like, even though you think, well, it's helping contract the heart and work better, it's only for for symptomatic relief. Okay, let's see, right? Yeah, anti-androgenic effects. Obviously hyperkalemia, right? Just be able to recognize that in the lab values. And then we have the ones that work on the ENaC channels, amiloride and triamterene. Not super important, but they're there. So again, they are potassium sparing. They're going to prevent that exchange from sodium and potassium. All right. And then carbonic anhydrase, acetazolamide, basically just helps to prevent bicarb. It's to prevent bicarb. You pee out bicarb, right? Is retained in the lumen. Yes. Okay. So it prevents reuptake of bicarbonate, right? So these are when you would want to use that. Mountain sickness makes sense because if you're in respiratory alkalosis from hyperventilating, you can use carbonic anhydrase. You'll pee out a lot of the bicarb and it'll acidify the blood and try to bring you back to baseline. Okay, so that's all you really need to know for that. right? Well, yeah. Yeah, so obviously if you're peeing out a lot of bicarb, you'll end up in metabolic acidosis. And crystal stones, yeah. Yeah, I don't know how important that is. All right, good. Again, I know I'm going kind of fast. If y'all have anything y'all want to bring up, just stop me. Osmotic diuresis, this will help, mannitol helps to bring all the water into the urine. It's an osmotic agent, so it'll bring a lot of fluid in so you could pee it out. Not really used. They probably won't ask you about that. Okay. ADH, this is not super important either, but ADH, right? Remember, brings free water back into the body. So if you have something like syndrome of inappropriate SIADH, of inappropriate ADH, you know, you can give something like this, right? There you go. And then you have your charts. If you're a chart person, go with that. All right, now anti-hypertensives, you know the staging by now. They could ask you that, but make sure, or pimp you in when you're doing small group with that. But this is what you should go with. Some textbooks or websites will give you differences. This is the standard that SGU uses, okay, for stage 1 and stage 2, or pre-hypertensive. Well, they don't even call it pre-hypertensive anymore. Just stage 1 and stage 2. All right. So again, with we're not going to go through how all this works. I want to just talk about the drugs. Right. So current treatments. All right. So again, if you're in heart failure, you want to decrease. You don't want to be in volume overload. You want to decrease the volume. So first line agents such as ACE inhibitors are going to be very important. You need to know which ones are first line, which ones are second line, and whatnot. Okay. So these all fall together. Remember, you never give an ACE inhibitor and an ARB together. They basically work the same. Okay. So you're going to give one of these two, throw a calcium channel blocker and a thiazide. You'll be good to go. You can also add a beta blocker and something like spironolactone too, if you need to. All right. And then ACE inhibitors, I pretty much know how this works now. They're going to help to block aldosterone downstream, or it's going to block angiotensin 2, and angiotensin 2 will activate aldosterone and ADH. So if you use an ACE inhibitor to block angiotensin 2, you can help prevent the reuptake of fluid, and you can help prevent that vasoconstriction from angiotensin 2, right? So it's a twofold effect. Big thing with ACE inhibitors, they increase bradykinin. Bradykinin will cause a dry cough. It'll also cause angioedema. So if that happens, you just switch the patient. If the patient comes in with a dry cough, you switch the patient from an ACE inhibitor to an ARB. No big deal. Okay. You can see, y'all all know now how aldosterone works through this process. All right. Now, super important, it's very good for diabetic patients. ACE inhibitors, pretty much first line for everybody, unless you're in like severe renal failure. But definitely with these diabetic patients, you want to give them an ACE inhibitor. Okay, now, what actually happens when you give an ACE inhibitor is that it can cause dilation of the efferent arteriole, okay? So if our glomerular filtration is going to go this way, right? Blood's going this way, and it has two choices. It either goes down or it goes this way, okay? If we dilate this, right, like we're doing here, we're technically gonna decrease our GFR. Okay? So ACE inhibitors will do this. ARBs will too. Because it's blocking this angiotensin 2, so you're not going to get constriction. So you can, now this is fine to a certain point, okay? So for people that don't have renal failure, decreasing your GFR a little bit is not that big of a deal, so you can use an ACE inhibitor. But when a patient gets into, say, stage 5 renal failure and their GFR is like 10%, you need to take them off of this because that 10% is all they have left, okay? But in a general sense, you can use ACE inhibitors unless there is a significant GFR reduction initially. Okay. All Patients, right? So yeah, so like and I think Dr. Clunes brought this up a lot. This bilateral renal artery stenosis. If you were to give an ACE inhibitor, it will cause a drastic decrease in GFR. So you need to be aware of that. So not only those patients that have severe renal failure, but with this bilateral renal artery stenosis, adding an ACE inhibitor will decrease the GFR a lot quickly. So you need to be aware of that. So never give an ACE inhibitor if it's bilateral. All right, yeah, you can't give it in pregnancy either. You can get congenital malformations and decreased development, yeah, in urea and renal failure, okay? All right, good. Come on, oh, that's it. All right, so far so good. ARBs, very similarly, they just don't activate bradykinin, so you won't get that call for the angioedema. And they end in sartan. All right, so same mechanism pretty much. Don't give them in pregnancy, same principle as ACE inhibitors. And again, with that bilateral renal artery stenosis, it is the drug of choice for unilateral. So make sure they're talking about bilateral. Too much decrease in GFR too quickly, not good. All right, and then renin inhibitor, you think they like this drug. I don't know what the pharmacokinetics of it, but they don't use it that much. I just remember it's a renin inhibitor because it ends in ren. Okay, but I doubt they'll ask you about this one. Okay, so then we get to our calcium channel blockers. Now, there are two classes. They're the non-dihydropyridines and the dihydropyridines. It is important to know the differences here. Dihydropyridines basically only work on the vasculature, okay? They're gonna work to vasodilate the vasculature. The non-dihydropyridines work on the cardiac myocytes and the vasculature, okay? So typically, if a patient just has benign hypertension and no heart failure, you just give them one of these and you just dilate their vessels. But if a patient does have some sort of heart failure and hypertension, you give them the non-dihydropyridines. I always got these confused. It was a pain. So I just remember DNA. So DNA, right? DNA, those go together. And those are just for the vasculature. That's what we're talking about here. The other ones go with the other set. All right. Good. So you know that they also fall in that class 4 of the antiarrhythmics, or calcium too, right? So those are when you're going to use those non-dihydropyridines. All right. Kind of just goes into the process, but it's a sodium calcium exchanger. So you're blocking calcium from being available to the myocytes. All right, so again, first line drug. And just take note, you would not give these dihydropyridines for cardiac arrhythmias. If you think about it, these are just working on the vessels. So if you vasodilate the vessels, you can get reflex tachycardia. It may precipitate some sort of arrhythmia. So just be careful with that. You'd want to give one of the non-dihydropyridines because it's actually working on those cardiac myocytes too. Yeah, here you go, that reflex cardiac stimulation. Big one, I put it in red. They like to test on that. Verapamil will cause constipation. Gingival hyperplasia as well. Now, the non-dihydropyridines, these are the ones that would fall in that class 4 that you'd want to give for certain arrhythmias. And then we're not going to talk about the diuretics again, but yeah, so again, the glutes is what you can use for that, for these thiazide adverse effects. Loops, we talked about those, potassium sparing. Was there a specific slide that said which ones are prevent myocardial remodeling? Maybe not. And then beta blockers, of course, these are basically just going to help to slow down. It's more of a beta-1 effect. You're slowing the heart rate down because if you think beta-2, well, you're preventing that vasodilation. You think of these as more of the beta-1 effect that they use, right? So you're thinking of like a atenolol and metoprolol. Remember, A through M the ones that fall A through M are selective. So they'll choose like beta 1 over beta 2 and N through Z, beta 1 equals beta 2, okay? So it's a little tricky. Why would you want to block beta 2 since it does vasodilation? But this is mostly, think about the beta 1. You're putting some relief on the heart from working so hard. Okay, and you could see this here. All right, the thing that they like to talk about with beta blockers is that in diabetic patients, when they have episodes of hypoglycemia, a lot of times the first symptom of that is tachycardia, okay? So if a patient's on a beta blocker, a diabetic patient is on a beta blocker, they need to be aware that they might not get that initial warning sign of tachycardia because the beta blocker is in essence slowing down the heart rate, okay? So that's a good test question. Obviously, you're not giving a beta blocker to someone who has asthma. All right, so alpha-1 blockers, remember alpha-1 works on those vessels to vasoconstrict. If you block those, you can vasodilate, right? So that's good. Also, they use it for BPH as well. Okay, so yeah, you're blocking that sympathetic response so you can, the patient can urinate better. All right, and then mixed alpha beta. Yeah, these are more common these days because you could get you can block that alpha-1 and you could also block the beta-1 of the heart. So you get vasodilation and you get a decreased heart rate. Clonidine is a tricky one because alpha-2 is more of an inhibitory, it's centrally acting. So it has this like autonomic effect of inhibiting the autonomic system. So it like slows down your sympathetics. They use that sometimes. The thing you have to watch out for this is if patients get off of this too quickly, they get what's called rebound hypertension. So their blood pressure skyrockets. Okay, so if you ever see rebound hypertension, they're talking about clonidine. It's classic for that. Here you go. Methyl-dopa, good for pregnancy. That's the drug of choice there, so keep that in mind. And then you have your direct vasodilators, okay? So hydralazine and minoxidil, which is Rogaine actually, causes hypertrichosis. They don't use it first line, but it works directly on the smooth muscles to dilate the vessels, okay? On the arterioles, direct vasodilators. All right. Watch out for that lupus-like syndrome. They'll just give you symptoms of lupus. They won't tell you it's lupus-like syndrome. So you need to know the drugs that go with that. And if there's any sort of malignant hypertension that you need to address immediately, minoxidil can work. But typically they talk about hydralazine. All right. Pulmonary hypertension. Remember, anytime you have pulmonary hypertension, it can lead to cor pulmonale, which means right heart failure. So you don't want that to occur. So prostaglandins are always going to help to vasodilate. So that's a good way of doing it. Endothelin is a vasoconstrictor. So if you inhibit that, you could be good. Sildenafil is Viagra, but it is a vasodilator. So it can be used in pulmonary hypertension. Okay. And you could see it is important that you know which they go with which. So ipoprostol is PGI2. I think that's really the only one you need to know. Bencentin, I don't know if they'd ask you about that. And they just like this one, the class that it works, right? So it's inhibitor of phosphodiesterase 5, increases cGMP, increases nitric oxide. So it'll improve blood flow, as Viagra or in the pulmonary system. Can't give it to a patient on nitric oxide. A lot of patients take nitro for angina. They take those sublingual tablets, nitroglycerin, and it'll help to vasodilate the coronary vessels, right? But so you can't give them something like this because that's too much nitric oxide. They'll vasodilate too much. They'll go into shock. All right, so definitely know these. These are very important, what comes with what, first lines versus second lines and stuff like that. And just knowing importantly, like diabetes, definitely get them on an ACE inhibitor that's renoprotective, stuff like that. All right, good. All right, then we get into the hypertensive crisis. So again, you like nitroprusside is a good one that you can use. That's typically what they use. This is the emergency situation. So you need to get prompt vasodilation. These patients coming in, their systolic pressures over like 200. Okay, it inhibits, I think, complex 4 of the electron transport chain. So it causes cyanide toxicity. You can give sodium thiosulfate to treat that. Yeah, not that that's high yield, that you'll get to that later. We talked about labetalol. I'm pretty sure labetalol is good for pregnancy as well. It doesn't say that here, but I'm pretty sure that's right. Vindolapam, whenever you think of a dopamine receptor agonist, think that it's good for the kidneys, okay? Typically, whenever, the only thing I've ever seen when they use something like this is when they're worried about the kidneys, such as renal insufficiency, okay? Because they have dopamine receptors, I believe, in the afferent arteriole that help to vasodilate, so you get increased blood flow to the kidneys. So that's good to know. Yeah, calcium channel blocker, of course, nitroglycerin. Yeah, but typically they would give nitroprusside. All right. Yeah, and then these are just, you can go through these on your own. Hydralazine is good for pregnancy as well. So anytime patient gets eclampsia or preeclampsia, you know that causes hypertension, you can give them hydralazine. All right, heart failure. Now, we talked about this, what the difference is, systolic versus diastolic. So systolic, you should say pump failure. If you're giving drugs to help with pump failure, you're going to give something that's going to help the pump work better. If remember, diastolic is talking about filling problems. So if you're giving something to help with the filling problem, you're giving something to help relax the heart. Now, there are some crossovers here that you want to give just in heart failure in general, but some of the specific ones, such as digoxin, right? You give it for systolic because it helps the heart pump better. Whereas for diastolic, you can give like a calcium channel blocker. It'll help relax the heart and help it fill better. Okay, so keep those in mind. You know, if you think about it, think through it, you really don't have to memorize it. It'll just make sense. Okay. Yeah. Okay. Right. So reduced ejection fraction. We're talking about an ejection problem. Okay. So it's dilated, it's floppy, and there's an ejection problem at this point. So spironolactone, direct vasodilators, those can be used. Inotropic agents such as digoxin. Whereas diuretics, the ones in yellow, you can use for either reduced or preserved. Okay, so ACE inhibitors, diuretics, beta blockers, give them for all. I think spironolactone may as well be for both, but direct vasodilators and inotropic agents you want to give for reduced because it'll help the blood flow, help the pump work better. Okay, so don't listen to me. Spironolactone apparently is only used in reduced ejection fraction. Okay, that's why it's in green. But if it's preserved, I guess you don't want to use that. Again, so preserved, we're saying that it's a diastolic problem. We want to be able to relax the heart a little bit more so that we can get more blood into it, right? So again, you could use diuretics, ACEs, beta blockers, and the one that you would want to use in preserved ejection fraction is calcium channel blockers, because again, that calcium blockade will help to relax the heart a little bit more. It'll help to feel better. All right, good classes, that's fine. Yeah, so here's the example of prolonging survival. They help to prevent myocardial remodeling. So by definition, you're helping with survival. Of course, they are teratogenic, so be careful with that. Same thing with the ARBs, direct vasodilators, talked about those. Here's one of those things that comes up sometimes. for whatever reason, ACE inhibitors don't work as well in African-American populations. So you can switch them. Instead of using the ACE inhibitor, you can use a direct vasodilator. Okay, just in case they ask you that on the exam. I don't know how clinically, if doctors even go through that process, but I think there were some exam questions that talked about that. Okay, again, remember direct vasodilators work on with nitric oxide. You got to watch out if the patient is on sildenafil. And then again, hydralazine, that lupus-like syndrome that comes up. All right, beta blockers, reverse cardiac remodeling, help with long-term survival. Okay, now this should make sense. If the heart can't properly compensate, right? If it can't compensate for the heart failure. So say the left heart's failing and the right heart has to get more blood to if it can't properly do that to keep the stroke volume up, you don't want to give a beta blocker, because the beta blocker is going to stop or decrease the blood flow. It's going to decrease the work of the heart. It's going to decrease contraction. So if you're decompensated, your heart's working just to keep you alive. So giving a beta blocker is not exactly a good idea. Okay. And we talked about spironolactone. Yeah, with those, remember they have those anti-androgenic effects. Hyperkalemia, watch out for arrhythmias. Okay, now digoxin's the big one. Again, they really don't use it that much anymore, but when it first came out, it was like this novel drug, you know, it like makes the heart just work better. Remember, it has this inotropic agent. It's a negative chronotrope, which it means it slows down the heart rate, but it's a positive inotrope, which makes it squeezes better, right? It contracts harder and it works. Yeah, you see that here. Right, and yeah, so by doing that, working together to have more of a less heart contraction, but when it does contract, it contracts stronger. That process will help to decrease myocardial oxygen demand, okay? And this is how it works. Basically, it blocks the sodium potassium ATPase. So sodium will be inside the cell. This is tricky. This is bidirectional, these little arrows. So what happens is, by blocking this, there's a ton of sodium in the cell. So the sodium over here wants to rush out of the cell. So it rushes out. That means calcium comes into the cell. So there's a lot of free calcium, okay? They could ask you about this process. So just remember, this goes both ways. So if you have a lot of sodium in, you kick the sodium out to bring calcium in. The more calcium you have, the stronger you can contract the heart, okay? Yeah, so atrial fibrillation. So the atria is just kind of shaken, right? You need to be able to say, slow down, let's have a nice concentric heartbeat, right? So atrial fibrillation is a good example where digoxin could be used. But again, digoxin is for symptomatic relief. It's not gonna help with cardiac remodeling or anything like that. And this is why it's really not used as much anymore, because of this toxicity, okay? That it could have. One of the ones that they talk about classically is this yellow hue in your vision. So be aware of that. Anytime they talk about that, or halos and dark objects, that could be digoxin toxicity. Now, these precipitating factors, what this means is if any of this is happening, when you give digoxin, it could lead to digoxin toxicity, okay? So if a patient has hypokalemia, that will block this pump, which means there'll be more sodium available to help to shuttle the calcium. So it can cause too much calcium intracellularly. But just in case these come up, it's a little complicated, but just be aware of these. These can lead to, if the patient is in a setting of this and they take digoxin, it could cause digoxin toxicity, okay? And these are the interactions. So whereas if you have hypercalcemia, it could lead to digoxin toxicity, or hypomagnesemia. They work opposite. Okay, so just in case they ask that, I don't know if y'all have come across questions like that. That is a little bit complicated, like I said, but those are some of the things. But the main one to remember is a setting of, you never want to give digoxin in the setting of hypokalemia, okay, because that'll make it worse. All right, then the adverse effects as well. Okay. Right, and so you never want to give it for a diastolic dysfunction. You always give it for systolic because it will help with contraction. All right. Treatment for diet, okay, we kind of talked about this. Here are some other inotropic agents. Go through these on your own. I mean, these weren't super important. CAMP, phosphodiesterase inhibitors, yeah, okay. I don't know that they'll ask about that. Remember when we talked about dopamine, we're talking about help with renal perfusion. Dobutamine, they only give this when the patient comes in and they're in complete heart failure, and it'll help to stimulate the heart, stimulate contraction. Glucagon can be used, increase CAMP, so similarly to like beta agonists as well, right? Works through a similar process. All right, now, again, like I said earlier, these antiarrhythmics are difficult, but the test questions weren't as bad as I thought. Like they only tested us basically on what I'm going to explain to you guys here. So there are two different electrical impulse graphs that we're going to look at. This is the myocardial, the one you know classically, right? So we have that upstroke of sodium, then the potassium, then that calcium plateau, and then potassium, and then sodium, right? So the class 1 and class 3 are going to work on this graph, okay? Class 2 and class 4 are going to work on the actual nodes, the SA node specifically, okay? So when we look at these, I mean, we've talked about this in FTM and stuff. I want to get to the drug. So as I said, you can see the two different graphs. Remember, 1 and 3, the sodium and potassium antiarrhythmics are going to work on this. And then 2 and 4, the beta blockers and calcium channel blockers are going to work on this, okay, the pacemaker graph. So it's very different and very important that you know the differences there. Okay, let's get to the drugs. So again, they briefly talk about these different arrhythmias, but we really get into it in term 5. You really don't need to know how these work right now. You just need to know the definition of how these drugs work. Okay, so the class 1, remember, so it's sodium, so we're gonna work on the myocardium. Okay, so 1A, B, and yeah, let's get to those. Okay, so the sodium. So we're working on the myocardial graph. Did they not show it again? Okay, here we go. Yeah, so you want to slow the rate of the phase 0 depolarization. And what you could do is you could see that here. So on a test question, they could ask you, they could say the patient has an arrhythmia. They want to use a drug that will not only extend QRS, but it'll also extend QT. Okay, so you would know the definition. That would be a good example of a class 1 antiarrhythmic. They may even give you this graph, okay? We had graphs like this. So make sure you're able to identify this graph and know which one goes with which, okay? Right, and there are some weird little side effects, like quinidine has this synchronism, blurry vision, tinnitus, and headache, even psychosis. So be aware with that. Another good thing that you could know now, anything that increases QT, okay, can lead to torsades de points. Now, why is that? If you extend, let's go back to the picture. If you extend this QT right here, what you're doing, like the longer, so by extending QT here, you're making this, technically you're making this whole interval longer. I mean, you're extending it here, But what happens in this zone is very dangerous. You're tempting fate here, because what can actually happen is you can get re-entrance. You can get abnormal polarizations here. And the problem is, the longer you prolong that QT, the more opportunity they have for an aberrant impulse to go through. Okay, so just keep in mind, anytime you prolong that QT, you can be at risk for getting torsades de pointes, which means it starts firing straight through. And so it's big for the class 3 drugs, but it can happen in these as well. Okay. Canamide's another one. Again, lupus-like syndrome. Good to know that. This is the other one, dysopyramine. I don't know that they asked us anything about that. Just know which drugs go with which class. Okay, good. Let's see. Okay, so now they could ask you, we want to use a drug that prolongs QRS but shortens QT. That's classic for these 1B antiarrhythmics, such as lidocaine, okay? So again, you have to be a cardiologist looking at arrhythmias to decide, do we want to shorten the QT or prolong the QT or whatever? So you don't really need to be able to differentiate types of arrhythmias with the drug. You want to just be able to identify what goes with what by definition. All right, but a caveat, it is good to know that lidocaine can be used for ventricular arrhythmias. Okay, so just know that too. It comes up in term 5 as well, but just keep that in mind. Okay, so then we have our class 1C. Now look at this. What if they said we want a drug that will prolong the QRS significantly but not change the QT? Well, then you could use the 1C drugs. Okay. So again, ventricular arrhythmias, but again, this could be used for either. So, you know, take that as with a grain of salt. This is a great example of something they could ask on the exam. I would put a star on this slide. So make sure you can differentiate these different graphs, which one's 1A, which one's 1B, and which one's 1C. All right, definitely high yield. Okay, phase 0 and 3, phase 0 and 4, and just phase 0 here. Okay. All right, and then our beta blockers. Now, we said this class 2, these beta blockers are going to work on the node. Okay, so we're looking at that nodal graph now, the SA node. So what they do by definition, they decrease the slope of this phase 4. Those initial phase 4 sodium funny channels. If you decrease the slope, it's going to fire less frequently. Okay, so you're going to get a prolonged or increased PR interval. Okay, and that'll help to slow down those SA nodes the SA node firing. All right, and then it just kind of goes into, you know, the side effects of these beta blockers. All right, now potassium channel blockers, class 3. We're going back to the myocardial graph. Okay, now look at this. Look what they do. They prolong this QT. That is what they do. They work on this repolarization phase, this phase 3 potassium channels. So what do you think is a big problem here? Torsades de pointes, right? Or having these new arrhythmias that form. Okay, so you have to be aware of that. Amiodarone is very tricky. I'm not sure that they use it so much just because it has so many side effects. Okay, so you can see here, like, it could be used in the atrial arrhythmias or ventricular arrhythmias. So it's not going to be important that you could differentiate what arrhythmia to use this with. You just want to be able to classify it, okay? So it's by definition going to prolong this QT phase. It's going to work on phase 3, this repolarization phase, by blocking the potassium channels. All right, and then here are some of the side effects here. Pulmonary fibrosis, that's a problem, right? It could cause hyper or hypothyroidism, get photosensitivity. Another thing, a big buzzword, blue skin discoloration. And then again, of course, it could cause torsades de pointes. All right, sotalol falls into the same category here as that class 3, and dofetilide too. Okay, atrial, let's use it primarily for atrial issues. All right, then class 4, now we're jumping back to the nodal graph, okay? So these calcium channel blockers, similarly to the beta blockers, will increase your PR interval. So we're slowing down the heart rate. Now, these will work on the calcium aspect. Remember this phase 4, and then this is phase 3. Excuse me, wait. Sorry, this is phase 4. This upstroke is the calcium phase, which is phase 0. So it's going to slow the rise of this portion of the action potential. Remember, the beta blockers worked on 4 over here, which was this sodium funny portion. Sodium funny portion. The sodium funny channels. The beta blockers worked down here on this portion, phase 4. They slowed the slope. They decreased the slope. Okay, that was the beta blockers. And now we're looking at this. This is called phase 0. This is the calcium phase. So if they slow this rise, these class 4s, then it'll help to increase your PR interval, so it can help to prevent tachycardia or arrhythmias. Okay, remember, we're using those non-dihydropyridines because they work on the heart as well as the vessels. Okay. And then you can see the atrial supraventriculars. Again, don't forget verapamil causes constipation. And then digoxin, we talked about that, positive inotrope, right? Negative chronotrope. Typically, okay. Yeah, so they'll use it to control ventricular rate if they did use digoxin. So a flutter or fibrillation. But again, like I said, y'all really, if y'all just know the definitions, what does what and works on what phase of those graphs, you're golden. Adenosine, yeah, very short acting, can help to fix arrhythmia short term. Right. So abolishing acute supraventricular tachycardia. So you can give adenosine, and it'll help to fix it in an acute setting. And I don't think they'll ask you about any of this, magnesium, atropine, anything like that. All right, what's left? I think they just go over, okay. And like, just know, okay, this should make sense that the ones that work on those nodal graphs are beta blockers and calcium channel blockers, right? Those were the graphs. The ones that worked on the muscle were the sodium and potassium. So 2 and 4, beta and calcium, work on the nodes. 1 and 3, sodium and potassium, work on the myocytes, okay? Other than that, like diving into this too much, just not, you don't really need to. All right. Yeah. So it should make sense. If you want to slow the rate down, you can give these beta blockers, calcium channel blockers. That should make sense. And then rhythm control can be done with these. Again, this is a little bit more than you really need to get into. All right. So anytime you have an angina, you can give nitrates. That's pretty much first line. It will help to vasodilate, help with that chest pain. Beta blockers will slow down the heart. Calcium channel blockers help to relax the heart. Ranolazine, it almost works opposite of digoxin in that it prevents intracellular calcium. Okay, so if you don't have intracellular calcium, the heart won't work as hard. It won't have as strong of contractions. All right, but you know how these work. Nitrates, nitric oxide goes through the cGMP pathway, guanylyl cyclase. All right, and much of the same here. Right, so if you keep in mind that in the beginning of the lectures, this lecture, which ones to use with angina, you want to slow down the work of the heart, oxygen demand, and you want to vasodilate. So think about that, and that'll help with the angina. First line is typically nitro. All right. All right, coagulation. This is I don't know that I'm even going to go through this. I think Dr. Dasso does a really good job explaining everything here with these. Know just what classes go with what, and you know what the major side effects are, right? But I think Dr. Dasso's test questions are very similar to his IMCQ questions. So just know what goes with what. Know, particularly know about heparin and warfarin, right? Remember, warfarin takes a little while to kick in, a couple of weeks, so you always give heparin first as you transition to warfarin. Know like heparin-induced thrombocytopenia, that's a big problem with heparin, and know that the side effects of warfarin too, in regards to like vitamin K. If you have too much warfarin, you can give vitamin K to help to alleviate it. All right, and then the hyperlipidemics. I mean, knowing, oh gosh, yeah. There were like hand signs for this, right? I forget them. Like 1 is chylomicron, 2 is LDL, something like that. I'm sure somebody has the picture. I might have used it in one of our old reviews. All right, so first line statin always, unless there's a reason not to give it. But knowing which ones directly do what, like statins, the big thing about statins is they decrease LDL. Like some of the other ones, I don't remember off the top of my head, but like fibrates will decrease triglycerides. Like that's a big thing. So knowing what their major effect is will be important. Niacin, remember that'll cause flushing. You can give aspirin prophylactically for that, but knowing stuff like hepatotoxicity and hypoglycemia as well, knowing that, yeah, LDL, yeah, there should be a table somewhere that has everything. Honestly, I might get 2 or 3 questions on this, so. Yeah, but yeah, so like, see what I have highlighted here? Statins work primarily on LDL. Fibrates are gonna work mostly on triglycerides. Niacin is gonna help with increasing your HDL and decreasing your triglycerides, okay? So these are kind of things that are important to know. Yeah, and here you go. So this would be good. If in doubt, just give a statin, except they're contraindicated in pregnancy.